Drug eruptions.
Definition. The expression, "for any rash, think drug," reflects the finding that drug eruptions can appear similar to many inflammatory skin diseases. The skin is the most common target of adverse drug reactions. Think drug reaction for any symmetric rash of sudden onset. The two most common eruptions for drug reactions are hives and morbilliform rashes. Of these two, morbilliform rashes are more common. A morbilliform drug rash appears as a generalized eruption of erythematous macules and papules, often confluent in large areas. Drug eruption, bright red macules and papules confluent in large areas.
History. The onset of a drug-induced morbilliform eruption is usually not immediate but rather begins within several days of the initiation of the drug. Onset is sometimes delayed for as long as 1 week but seldom longer. Because no laboratory tests are available to identify the responsible drug, reliance is placed on the history. For patients receiving multiple drugs, this presents a problem. In selecting a single drug from a list of many, the two variables to be considered are, 1. The temporal relationship between the initiation of the drug and the onset of the rash, and 2. The likelihood that a given drug is likely to cause a drug eruption. In selecting a putative drug, it is helpful to construct a graph that depicts the patient's drug history. Graphic depiction of drug history. In the example in graphic, drugs A, B, and C are unlikely to be implicated because the patient had been receiving these agents for months. Drug D was stopped 4 days before the rash began, thus making it a less likely cause. Drug G was started 6 hours after the rash appeared, and drug H was started the following day. Drugs E and F were started 2 days before the rash and therefore have the best temporal relationship. Drug E is a cephalosporin, a well-known cause of rash, and drug F is codeine, a rare cause of morbilliform eruptions. Therefore drug E is the probable cause and is the first to be discontinued. Remember to include over-the-counter medications such as vitamins in your exposure list as well as PRN medications for inpatients, such as furosemide, which contains sulfonamide, a common cause of inpatient drug reactions. In patients with drug rashes, itching is usually present but is not helpful as a diagnostic marker. Fever is rarely found. Most drug eruptions do not cause major morbidity, and the signs and symptoms are mild to moderate, resolving in 1 to 2 weeks. Physical examination. The eruption is generalized and composed of brightly erythematous macules and papules that tend to be confluent in large areas. Characteristically, the erythema is intense or drug red. Drug rashes usually start proximally, e.g., affects the upper chest and back first, and proceed distally to the arms and legs, with the legs being the last to be involved as well as the last to clear. Pustular drug eruption. Note the symmetric distribution of minute pustules. It is important for the physician to recognize 2 life-threatening drug reactions, 1. Toxic epidermal necrolysis and 2. Stevens-Johnson syndrome. Toxic epidermal necrolysis is characterized by widespread erythema, greater than 30% body surface area, and full, epidermal thick skin separation. Transfer to a burn unit is critical. The erythema of Stevens-Johnson syndrome typically involves more than 10% body surface area and involves 2 mucosal surfaces, example, conjunctiva and oral mucosa. Hemorrhagic crusting of the lips is pathognomonic. Toxic epidermal necrolysis. Note erythema and full-thickness skin separation. Stevens-Johnson syndrome. Note erythema and involvement of 2 mucosal surfaces, hemorrhagic lips and conjunctiva. There is often an overlap of the features between these 2 conditions. For practical purposes, it is important to diagnose a life-threatening drug reaction. Both potentially fatal drug reactions require prompt evaluation, recognition, discontinuation of offending medication, and intensive supportive care. Drug rashes are usually 1. Bright red. 2. Confluent in large areas. Other patterns of drug reactions. Acneiform drug reactions, lithium, epidermal growth factor inhibitors, steroids, isoniazid. Pustules, acute generalized exanthematous pustulosis beta-lactam antibiotics, macrolides, calcium channel blockers. Erythroderma, allopurinol. Erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, anticonvulsants, allopurinol, nonsteroidal anti-inflammatory drugs, NSAIDs, sulfonamides. Vasculitis, NSAIDs. Psoriasiform dermatitis. Interferon and granulocyte colony, stimulating factor, tumor necrosis factor inhibitors, lithium, beta blockers, antimalarials. Angioedema, angiotensin-converting enzyme inhibitors. Acneiform eruptions, epidermal growth factor inhibitors. Skin cancer, squamous cell skin cancer, BRAF inhibitor. Morbilliform eruptions, lichenoid eruptions, vitiligo. Immune checkpoint inhibitors. Bullous pemphigoid, furosemide, dipeptidyl peptidase 4 inhibitor. Drug-induced hypersensitivity syndrome. Anticonvulsants, lamotrigine, sulfonamides, allopurinol, minocycline. Differential diagnosis. The differential diagnosis includes viral exanthem, toxic erythema, and chronic exfoliative erythroderma. A viral exanthem and a drug eruption can be indistinguishable clinically. Often, a drug eruption is much more erythematous, more confluent, and more pruritic. The presence of viral signs and symptoms favors a diagnosis of a viral exanthem. Toxic erythemas include scarlet fever, staphylococcal scalded skin syndrome eruptions, and Kawasaki syndrome, mucocutaneous lymph node syndrome. Features that help to distinguish these rashes from drug eruptions include a sandpaper-like texture of the toxic rash, mucous membrane involvement, scarlet fever, and Kawasaki syndrome, the presence of fever, and a focus of infection or the presence of lymphadenopathy. When a generalized erythema becomes chronic, it is called an exfoliative erythroderma, exfoliative because of the prominent desquamation. Long-term administration of an offending drug is one cause. The other three causes are generalization of a primary skin disease, most often, psoriasis or atopic dermatitis, malignancy, most often, the Sézary variant of cutaneous T-cell lymphoma, or an idiopathic disorder. Staphylococcal scalded skin syndrome. A toxin-mediated eruption characterized by erythema, skin separation, split is at granular layer and not full-thickness epidermis, and focus of infection, nares. Exfoliative erythroderma. Laboratory and biopsy. No laboratory tests can determine the diagnosis of a drug eruption or the incrimination of a specific drug. Peripheral blood eosinophilia is sometimes present and may heighten the suspicion of a drug reaction. Skin biopsy is most often performed in patients with chronic exfoliative erythrodermas, especially to rule out cutaneous T-cell lymphoma. A drug eruption shows a superficial and deep perivascular inflammatory cell infiltrate. The presence of eosinophils in the infiltrate is an important clue suggesting a drug-related cause. Skin tests for penicillin may be useful for the diagnosis of immediate hypersensitivity reactions, hives and anaphylaxis, but not for morbilliform eruptions. Skin biopsies can also help distinguish the level of epidermal separation for toxic epidermal necrolysis, full thickness, versus staphylococcal scalded skin syndrome, granular layer. Epidermis, normal. Dermis. Superficial and deep perivascular inflammatory cell infiltrate that includes eosinophils. Therapy. When the offending drug is identified, it should be discontinued. If the patient is taking multiple drugs and it is not possible to be certain of the offending drug, the number of administered drugs should be reduced to an absolute minimum, and any remaining possible offenders should be changed to alternative agents when possible. Therapy otherwise is symptomatic, with antihistamines, e.g., hydroxyzine 10 to 25 mg 4 times daily, most often used for the pruritus. Moisturizing creams are helpful during the late desquamative phase of the reaction. Topical steroids are of little value. Systemic steroids are rarely required but are helpful for the patient experiencing intense pruritus. Intensive care therapy is necessary for life-threatening drug reactions. Immediate transfer to a burn unit is important for toxic epidermal necrolysis. Therapy for drug eruptions. Initial discontinuation of the offending drug. Antihistamines. Hydroxyzine, Atarax. 10 to 25 mg QID. Diphenhydramine, Benadryl, 25 to 50 mg QID. Moisturizers. Eucerin cream BID. Alternative. Systemic steroids, prednisone 1 mg per kilogram, then tapered dose over 7 to 10 days. Intensive care therapy for life-threatening reactions. Course and complications. Drug eruptions clear slowly with time after discontinuation of the responsible agent. The time required for total clearing is usually 1 to 2 weeks. For several days after the offending drug has been stopped, the eruption may actually worsen. Complications are uncommon and primarily cutaneous. When large areas of skin are inflamed, increased body heat and water loss occur. For a patient who is already seriously ill, this could be a problem, but for most patients, it is not. One main risk of continuing an offending agent in the presence of a drug eruption involves progressive worsening of the rash, possibly eventuating in toxic epidermal necrolysis, which is characterized by the loss of large sheets of epidermis. Fortunately, this complication rarely occurs. The mortality rate for Stevens-Johnson syndrome approaches 5% and for toxic epidermal necrolysis 35%. Sometimes a drug eruption clears despite continued treatment with the offending agent, although this approach is not desirable if an alternative drug is available. If the responsible drug has been identified, the patient should be advised to avoid the drug in the future, and the medical record should be clearly labeled. One unique adverse drug reaction is drug-induced hypersensitivity syndrome, aka drug reaction with eosinophilia and systemic symptoms, DRESS. A morbilliform eruption often develops 2 to 3 weeks after exposure to a limited number of medications. Facial swelling is a unique physical examination finding. The syndrome is characterized by fever, elevated liver function tests, eosinophilia and lymphadenopathy. Prompt discontinuation of the offending drug and a course of systemic steroids typically leads to a quick recovery of laboratory abnormalities and clinical findings. However, all patients should be monitored long-term to be evaluated for potential autoimmune sequelae. Pathogenesis. Although specific immunologic and non-immunologic mechanisms have been documented for some types of drug-induced cutaneous reaction, example, hives and vasculitis, the mechanism for the morbilliform eruption remains unclear. Increasing experimental evidence points to a major role for cellular immune, type 4, processes. The clinical course with delayed onset and prolonged duration of the rash also favors this mechanism.
Clinical case. A 32-year-old woman presents with a 3-day history of an intensely pruritic, symmetrical erythematous maculopapular rash that began on her trunk and rapidly spread to her arms and legs. She started amoxicillin clavulinate 8 days ago for acute sinusitis. She denies fever, mucosal involvement, blistering, skin pain, or previous similar episodes. Physical examination reveals widespread blanchable erythematous macules and papules involving the trunk and extremities. The face, palms, soles, and mucous membranes are spared. Laboratory investigations show a normal complete blood count and liver function tests. What is the most likely diagnosis? A. Acute urticaria. B. Morbilliform maculopapular drug eruption. C. Stevens-Johnson syndrome, SJS. D. Drug reaction with eosinophilia and systemic symptoms, DRESS, syndrome. E. Pityriasis rosea. Correct answer. B. Morbilliform maculopapular drug eruption. Explanation. Morbilliform maculopapular drug eruption is the most common type of cutaneous adverse drug reaction, accounting for approximately 90 to 95% of drug eruptions. It typically appears 5 to 14 days after initiating a new medication, or sooner upon re-exposure, beginning on the trunk and spreading symmetrically to the extremities. Common causative drugs include beta-lactam antibiotics, sulfonamides, antiepileptics, and allopurinol. The absence of mucosal involvement, blistering, skin tenderness, systemic illness, eosinophilia, and organ dysfunction helps distinguish it from severe cutaneous adverse reactions, scars, such as SJS, TEN and DRESS. Why the other options are incorrect. A. Acute urticaria, characterized by transient wheals that usually resolve within 24 hours, not fixed maculopapular lesions. C. Stevens-Johnson syndrome, SJS. Typically presents with painful targetoid lesions, mucosal erosions, epidermal detachment, and systemic symptoms. D. DRESS syndrome, usually develops 2 to 8 weeks after drug initiation and is associated with fever, facial edema, eosinophilia, lymphadenopathy, and internal organ involvement. E. Pityriasis rosea, usually begins with a herald patch followed by oval lesions in a Christmas tree distribution and is unrelated to recent drug exposure. Key learning point. Any patient presenting with a new, symmetric, pruritic maculopapular eruption should be questioned about medication started within the previous 1 to 2 weeks, as prompt identification and discontinuation of the offending drug are the cornerstone of management.